Hey Doc, it's Nick. Great case here. Looking to finish up the endo on number 4. It looks like you started to put some calcium hydroxide in. From what you described, this sounded like a 1-2 situation. As we know, especially upper premolars, they come in a variety of different iterations of canal sequencing or sequences. So in this case here, it looks like, or from what it sounded like, it was one canal that split into 2. Obviously, one of the nice things about CAT scans is we can actually answer that question with a high degree of certainty so that we know exactly what we're dealing with. People often will say that they don't do molar endo. I often chuckle because I think these cases are sometimes more complex than 3 canals that we know are not joining back up later in the canal system. So I consider upper premolars as hard, if not harder some of the time, than molars when it comes to endo. Your question was really how to obturate, and I'll just kind of summarize what you said you've done up to this point. You had a hard time using rotary files to get past maybe the apical third, and you surmised correctly that it was probably a ledge or a split or some sort of aberration in the apical third that prevented the rotary from getting down in there. So you did what you should have done, which is pre-curved K files and hand filed to a 35. Sometimes that is the only way we're going to do it, in great part because it's harder to pre-curve nickel titanium rotary files. With that said, the new version of nickel titanium files are better because they can be pre-curved. They don't have memory, so not having memory with NiTi is advantageous. Having memory means it's more likely to stay straight. You're more likely to get transportation of the canal. So lack of memory is a good thing when it comes to files, but even still, because it's rotary, it's hard to keep that pre-curve or that modification to the K file where you want it. So sometimes we have to do what you did, which is to hand file with a 0.02 taper K file. It is what it is. It sounds like you were able to get to where you needed to go. So now you're at proper length. You got your radiograph, and you have a sense that there's something down deep that is different, that's preventing you from using rotary. One of the nice things about CAT scans and getting the CAT scan as a pre-treatment radiograph is the following. So if you come over to here, this is the in vivo software. Under section, click on additional view, custom section, create, and then I come like this, and I want a transverse section of that root. So essentially what I'm doing is I'm taking a 90-degree or orthogonal image of what the PA would show me. And that's what we get down here. And this is really where the magic starts to happen. Hold down the control button to zoom in. And as you can see here, you actually had 2 canals that came into one that look like they go back into 2. So we'll call this a 2-1-2 situation. Definitely a difficult one for sure. What I'll do is I'll come over here and I scroll back and forth, up and down, to get a better sense of what's going on. Yeah, definitely a 2-1-2. Let's start with the 2-1 situation, that more coronal section. It's not uncommon to try to get rid of this isthmus of the tooth in order to create more of an open canal. I can't say that there are studies to prove or disprove the following comment, but I don't think this adds any structural integrity to the tooth. As I say that out loud, I feel like I'm saying to myself, of course it helps. But in reality, you're more likely to have issues due to lack of proper obturation by having that there than if you removed it. What I would say is if this is thin, I would probably try to remove this. And what I would use is either an SX file where I'm going down one canal and then brushing over to the side. As always, the SX file is never meant to be pushed apically. It's always meant to go to resistance and then be used in a lateral sense. SX files breaking is 100% due to the fact that apical pressure was placed. That's not how the file is designed. It's not what it's meant to do. But it's meant to almost transport the canal just like a Lindemann burr would do with implant osteotomy translocations. So I would either use that or a Gates Glidden to open that up, or I would just use my wave file and I would transport that. Try to open this up as best you can. If you can't because it's too big or you don't want to do it, then you treat it like two separate canals. Let's continue the conversation as if that was the case, that they're two separate canals that maybe meet as we go more apical, and maybe they don't meet. How do we know? The simple test is the following. I'm going to use this view right here. So let's just picture in our mind's eye that this is an entire separate canal from this, and they meet along the way. They have communication, but they're separate and distinct in the fact that you're able to put a master file, whatever that master file is, if it's a size verifier for the yellow, the small wave 1, or the primary, the red, or you're just going to 35 hand file 0.02 taper, and you want to ask the question, do these meet? I think we all know this, but I think it's worth reiterating. You put one file in to length, and then you try to place a second file to length. If that second file doesn't go to length, odds are you're binding on the first file. You then lift that first file, and if the second file goes to length, you then know that the two files can't coexist at the apex together. So what that means is that this diameter here is actually not wide enough, or they meet together and it's actually one portal of exit. We call that a 2-1 situation or a 1-2-1 situation. I think you and I have talked about that before, so I don't think that's surprising. Using that technique with paper points and gutta-percha points is often a way to gain some sense of what's happening here. With that said, if you get a CAT scan, you'll know the answer to the test before you take the test, which is why we advocate for CAT scans for all endo, especially upper premolars. If there's a tooth that requires a CAT scan, it's this guy right here for this very reason. Lower incisors is another one. Those are very tricky to do, in great part because they often have this 1-2-1, 2-1-2 iteration of the canal anatomy. So let's say you instrument here to a 35 and a 35. You have to then ask the question, can I get two 35s in there at the same time? That will answer the question, how do I obturate this? Because the best way to obturate these is to have one filled with a file or a paper point, and then you obturate that first one, let that gutta-percha fully set, then you take out whatever was acting as an obstruction, and then you obturate that second one. Ideally, that's what you're going to do here. So what I would recommend, let me just take another look at the canal anatomy. So you definitely have two separate and distinct canals. So here's what I would do. Because at the office we have both warm vertical and carrier base obturation, this is how I would handle this. I would take, let's just assume these are both red. I don't know what your final master apical file was in relation to the wave 1 system, but let's just say you open these both to the red, the primary, which is a 250406 taper, 06, sorry. Put your sealer in both. I would put a master apical gutta-percha point from the GuttaSmart system in one canal. I would place my size verifier in the other, make sure I can passively go to length. If so, take it out, use guttacore in that first one. I would then let it set, maybe 30 seconds. Reason being, you want that gutta-percha to cool so that when you pull this out, you don't get any pulling of the gutta-percha in this area. You then pull, you don't have to pull out that first one, which is a gutta-percha point. You then use the warm vertical obturation to burn out down to about here, which will heat up some of the gutta-percha and further fill in this isthmus zone that hopefully was completely filled with the gutta-percha from the wave 1, sorry, the guttacore carrier-based obturation method from that first canal. But you would then burn down, doing your warm vertical, compress this area the best you can, and then backfill with the GuttaSmart warm vertical technique using hot gutta-percha or warm gutta-percha. So that would be how I would do it. There's many, many ways of doing it. You could do guttacore in both. as long as you have that other canal, the second canal, filled with something, whether it's a paper point, a gutta percha point, or a size verifier, something that occupies the space so that you can compress all of that warm gutta percha into this isthmus without it flowing and blocking you out. So as long as you have something in that other canal, it really doesn't matter how you do it, whether you do warm vertical for both or if you do carrier-based obturation for both. Let's just say this was one portal of exit, so you had a 2-1 situation. So you had two separate canals up in the chamber that eventually merged into one. In that case, I would use either warm vertical, which is the Gutta Smart system, or carrier-based obturation, which is the guttacore system for that first one. But I would then use guttacore for the second, knowing I'm not going to go all the way to length. The reason I like that is I do think that we get more thermoplastic gutta percha in odd areas with carrier-based obturation. So I don't know if that's translating very well as I'm saying it out loud, but that's how I handle 2-1 situations, or 1-2-1 situations where there's one portal of exit. So I hope that makes sense. Let me just see if there's anything else in this canal worthy of consideration. Upper premolars, I always flatten this cusp, get that out of potential lateral excursive interference. Obviously going to put a crown on it, but in the meantime, it's always good to get rid of these sharp edges just to prevent a fractured root from happening. The last thing I'll say is when we obturate using these more advanced thermoplastic obturation techniques, I'm finding we don't need a lot of sealer. So what I would recommend, and we've talked about this in the past, but I think it's worth reiterating, I'll put in sealer, and then with a paper point I really go up and down and I'm trying to coat all of the walls the best I can, but then I'll follow it up with 4 to 6 paper points to pull out as much sealer as I can. As with modern obturation methods, we're using thermoplastic gutta percha to go everywhere, not sealer. Sealer, unfortunately, is still being taught to be placed in the way that it was placed back when cold lateral condensation was the primary method for obturation. We now know that that's not how to obturate teeth. I'm amazed that schools still teach it. It has no benefit. It has high risks. So placing the amount of sealer that we need for a antiquated obturation method, I think we're missing the point. So place as much sealer as you want, but then pull out 95% of it. So really what you want left is what's coated on the walls. So what I would say is place your sealer in both canals and then use a pack of paper points in each canal to pull out as much sealer as you can. What is left, if you do good obturation with warm vertical or carrier-based obturation, will be the proper amount so that you get very little, if any, puff. There's a lot of controversy over whether or not the shoulder puff is indicative of clinical success or not. Topic for another day. I personally love a very small puff to confirm apical patency. Tells me that I cleaned everything out, but not too big of a puff that we bother the biology around the apex. Big puffs are not necessarily what we want anymore. All right, hope this helps, and let me know if you have any further questions. Take care.